on this computer. Okay, so now we're recording. And then I'm going to share screen. So we have nine participants, plus myself. And then I guess Jenna and Isaac will not join. So we're missing two people. Who are the two people? Fatima, right? Or is Fatima here? Fatima and Dana. Okay. Okay, let's start. I'm very, very glad to be able to be with you today, and to come back to my regular schedule. And I hope that, you know, I know having like a recorded session is really not like having a live session, and it's definitely not like having a face-to-face session, I guess. So, but last time I had to do it by recording because my Thursday was very unpredictable, in fact. Okay, so we'll go over the life course theory today. And I acknowledge that the article on diabetes, the methods section was difficult. For those of you who read it, I actually didn't get a chance to read the article on dementia. Although I've read quite a few of life course articles on dementia and health and old age. So if you have any questions, I can probably answer, and we can talk about the issue, not necessarily the article itself. But we'll talk about the life course and this concept of the long arm of childhood exposures, the long reach also, the long reach of childhood disadvantage of or childhood exposure. But before we do that, I wanted to start by just going over the fundamental cause principle because we didn't meet in person and I didn't get a chance to answer any of your questions. So I'll go over just a couple of things related to the fundamental cause. And then if you have any questions or any comments, please share them before we move on to the life course. So you've all submitted your third assignment, which had, you know, basically which revolved around the fundamental cause. And all of you did very well on that assignment. So, okay, so the fundamental cause theory, which was developed and written about, not necessarily developed, but like conceptualized and written about by two researchers, Link and Phelan and Link, who are a couple actually, sociologists. And they've done a lot of work to develop basically this conceptual frame of thinking about basically the determinants of health. And there are two main principles to the fundamental cause. The first is that really we have to think about the fundamental causes of poor health and good health. We cannot just think about the pathways or the risk factors. Because the effects of the fundamental cause cannot be eliminated by us addressing these pathways or risk factors that link to disease. So in the example you had in your assignment on smoking in Lebanon, smoking is really a risk factor. Smoking is a pathway or a mechanism. It is not a fundamental cause. In fact, there's some evidence that's coming out of Europe right now that shows that as smoking rates, as cigarette smoking rates go down in many of Western European countries, a new mechanism is actually taking precedence in terms of linking the fundamental cause to cardiovascular disease and cancer. Okay, so smoking for decades has been the main mechanism linking level of education, at least since the 1960s, linking level of education, lack of access to resources, and cardiovascular disease and lung cancer. Okay, as smoking rates go down, what's going to happen is another mechanism is going to replace smoking. And the theory coming out of some research that's being done out of based on European data is showing that physical activity now is the main mechanism that is linking fundamental causes to poor chronic disease outcomes. Okay, so if you remember the session that I recorded 2 weeks ago, let's say crowding linked poverty with tuberculosis 100 years ago. Okay, as crowding and housing conditions improved, and as tuberculosis no longer the leading cause of mortality in many parts of the world, then crowding was replaced by behavioral risk factors such as smoking. Okay, and smoking then started to link poverty and low level of education to chronic disease outcomes. What we are starting to see now, and the evidence is very new, is that cigarette smoking may be replaced by physical inactivity in some countries as the mechanism that is linking fundamental causes to poor chronic disease outcomes. Okay, does everybody hear me okay? Yeah, I think.
Yes, doctor, yes.
Yes. Okay.
Yes, doctor.
Great. Okay. So the other thing related to this first principle of the fundamental cause is that a fundamental cause can affect, okay, it's all yes, can affect multiple disease outcomes through multiple mechanisms. So poverty can affect, let's say, infectious disease through exposure to pathogens. Poverty can also affect cardiovascular disease through unhealthy diet or poor quality diet, for example. So it's the same fundamental cause, but the mechanism is different and the disease outcome is different. So this is the first principle. The second principle, which is really interesting and has been tested only a few times, you have one example, you read one example, which is the HPV vaccine, the example of the HPV vaccine, but also there are some examples related to some rare cancers, for example, where the fundamental cause principle 2 operates. Also, statins related to lowering cholesterol is another example where a fundamental cause, principle 2, is at play. So let me just go over what principle 2 is. This principle basically suggests that the impact of the fundamental cause becomes really clear and apparent under changing conditions. So as you all know, when the COVID-19 pandemic started, the first couple of months, everybody was saying, you know, the virus doesn't know race, the virus doesn't know, I don't know, class, doesn't distinguish between the poor and the rich. But then very quickly, you know, once we started to look at the data, we started to see that, in fact, the risk to COVID-19, both the risk to infection of COVID-19, but also the risk of developing severe illness because of COVID-19 was very much determined by fundamental causes. So people who had lower incomes, lower education, people who worked in essential jobs and couldn't work from home, for example, and couldn't protect themselves, were at a much higher risk of COVID-19, both infection and severe illness. It's not only an illness that can expose a fundamental cause or the dynamics of a fundamental cause. It's also sometimes a new treatment, which is very strange and counterintuitive because we're waiting for the vaccine for COVID-19. Okay, we're thinking, okay, we want this vaccine. This is going to be a savior for us, for humanity. Okay, what will happen? You know, I'm almost sure this will happen, is that the introduction of the vaccine itself will basically start to distinguish those who have resources from those who don't have resources in both the access to the vaccine and in the risk to contracting COVID-19 later on. This is what you saw with the HPV vaccine, whereas before the introduction of the vaccine, okay, there was no vaccine. So there was no, you couldn't see inequities or disparities in the population in terms of who got vaccinated and who didn't get vaccinated. But shortly after the vaccine was introduced, then you start to see that there are individuals who have resources, whether because they have health insurance or whether they have higher level of education, they can utilize knowledge, or whether because of race, ethnic background, which is related to exclusion basically in society. So individuals who were excluded because of income, because of racial, ethnic background, because of level of education, they had much lower access to the vaccine, to the HPV vaccine. Another example, which is even a more complicated article, test of the principle 2 of the fundamental cause, which I didn't share with you, but I can for those of you who are interested, is basically following up historically with what happened with cholesterol, with people's risk of cholesterol or ability to manage cholesterol after the introduction of statins as medication for cholesterol. So this medication was developed in the 1980s, and then it became approved in like the late 1980s. Shortly after statins were introduced, the data started to show disparities or inequalities of who could control their cholesterol levels and who couldn't. So again, similar to HPV, individuals who had knowledge, who could access this knowledge and utilize it, individuals who had health insurance, individuals who had economic resources were able to use statins and lower their cholesterol. And on the other hand, those who live in poverty and have less education, then you started to see that the level of cholesterol didn't go down in this population. So now in private hospitals in Lebanon starting to offer paid vaccinations, the gap will be wider. Absolutely, absolutely. Not only that, but now, what you're going to see in Lebanon, I think, Dalia, you're talking about COVID. What you're going to start to see in Lebanon is that individuals who work for companies and who are able to maintain their jobs will have access to the vaccine, because now the private sector in Lebanon is very interested in vaccinating their employees in order to be able to open again. And AUB is also planning to vaccinate students and faculty and staff in order to be able to open in the fall. So this will inevitably create disparities in terms of both access to the vaccine and risk of infection to COVID. Okay. Yeah, the bank sector, yes, and universities and other businesses as well. Okay. So, are there any questions or points that you would like to share before we move into the life course theory? Anybody?
I just wanted to add regarding HPV vaccines.
Yes.
I did a study on HPV vaccines. We intended to measure the awareness and attitude of primary healthcare physicians towards advising the public about HPV vaccines. Unfortunately, in some countries, HPV vaccines are very rare, and the government does not support them for a simple reason. They believe that the rates of cervical cancer are within controllable rates, so it's not cost effective to generalize and make it a public policy to recommend HPV vaccines for the public. This could be a fundamental cause in terms of the general system does not support a culture of HPV vaccine, rather than an individual reason that might oppose it. Yeah.
Sure. So the HPV is a very special case, because in some cultures, it is difficult to promote a vaccine that is related to, basically sexual behavior, and to basically tell parents that we want to vaccinate your 11 or 12-year-old daughter or son, because if they become sexually active, then this will protect them. So yes, absolutely. I've read a couple of systematic reviews actually, or reviews, not necessarily systematic reviews of research that's been done on HPV in the region. And apparently cost is also an issue. It's not only the cultural meaning of HPV, but also whether it's covered by insurance or not, because I think it costs at least $500, the three doses. So I was surprised that the cost was just as important in terms of like as a reason for accepting or not accepting the vaccine as cultural factors as well, sociocultural factors. Okay, let me see the chat. Okay. 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 So I wanted to early on in the presentation present the tips about tea because I forgot to do that last 2 weeks ago. Actually, I remembered after I recorded the session. So, anyways, this time I wanted to introduce you to oolong tea. Oolong. We think of tea in terms of color, whether it's black or green or even white tea. And now there's something called yellow tea that I need to read a little bit about. So oolong tea is, I don't know if any of you notices or reads what type of tea that you buy or drink. If you drink tea, some of you may not drink tea, but it's Chinese tea, and it's there's a theory that it comes from the word wulong, which means black dragon in one of the Chinese languages. It's neither black nor green tea. It's a special kind of tea that is partially oxidized. Reem, you didn't like the taste of oolong? Okay. It's supposed to be more exquisite than pure black or pure green tea. And it's oxidized in very different ways depending on what's called the tea master. Depending on whoever processes the tea leaf, it's basically their taste. It's how they process it. So it can look like pebbles, for example, and look like just any green tea, or it can be really dark tea leaves and look like black tea. It depends on who makes it, I guess. So, and these are the tips about oolong tea is that, I mean, it's not just for oolong tea, but as you know, tea should be stored in like a dark container. It shouldn't see light in a dry and cool place. And apparently tea should be kept away from coffee. Tea and coffee don't like each other. And tea starts to become stale if it's close to coffee. So you need to keep them in different cupboards, I guess, the tea in one place and the coffee in another place. And one thing I wanted to tell you actually is that if you drink loose leaf tea, not tea bags, you can steep the tea for up to 3 times. So you steep the tea in water, in less than boiling water for not more than 3 minutes. I don't think you should steep it for more than 3 minutes. And you can use it more than once. I actually find that the second time I pour water on the tea, it tastes better than the first time. And then by the third time, you start to lose taste. You don't get the tea flavor anymore the third time. But the second time is really, for me, at least with green tea, I find that the second time is tastier than the first time I steep it. And this is what I recommend, is that tea should be drank pure, without sugar, without milk. I think sugar and milk ruin the flavor of tea. So that's that for oolong tea. I'm for the next. By the way, this is like our 10th session, and we have three more sessions. So I'm gonna try to to think about tea or even coffee from other parts of the world, because I think that we focused a lot on China and Asia, which is natural actually when we think about tea. But apparently Kenya, for example, is one of the best places for, not one of the best places, but one place where some of the best tea is grown. So I need to explore that for next time. Okay. So that's your tea tip for today. So let's start to talk about the life course. And I actually didn't prepare any like activities for today. So I would like you to jump in. Just raise your hand if you have any comment or question, and jump in and participate rather than wait for me to organize, because I didn't actually organize like an actual activity. And I see that Jenna is with us, so that's great, Jenna. Okay, so the life course. The life course is actually something I work with a lot, and I think about a lot, and I'm reading quite a few articles on the life course. I'll let you know later on in the session what I'm reading. But the life course is actually an extension of the fundamental cause theory. It's not a theory that contradicts, or it's not necessarily a separate theory from the fundamental cause. It definitely doesn't contradict the fundamental cause. It complements it, and it's more of an extension of the fundamental cause in the focus on the importance of socioeconomic conditions in determining health outcomes. Okay. The life course theory, it's basically, if you remember the first slide, my cover slide, the life course theory is basically about the long reach of childhood conditions on health in adulthood. Okay, so the life course basically argues that you cannot think about health in adulthood without thinking about what the person underwent or what the person experienced in childhood. There are some developmental psychologists, in fact. I don't know, some of you might, I know Frank has a psychology background, but some of the others also may have some background in psychology. There are some developmental psychologists that say that whatever happens before 5 years of age will have an impact until the end of life. And whatever you can't fix by 5 years of age, you cannot fix later. Lamia, you're saying 7?
Yes, I read the theory about before 7.
Before 7?
Yes.
Okay. Okay, before 5, before 7. I read 7. I'm sorry, I read 5. But the point is that it's really early childhood development. That early childhood development is, let me put this here. That exposures in early childhood development is really fundamental. Okay, this is not to say that children are not resilient, or not only children, but that people are not resilient and that they cannot overcome adversity in early development. However, it basically says that certain exposures in early childhood, and we'll talk about lead exposure, lead in the blood, for example. We can talk about some exposures in utero. And maybe exposures, psychosocial exposures as well, not necessarily biological, that can have a very long-lasting impact. Okay. The life course theory takes into account the temporality of exposures, and basically integrates temporality of exposures. And the important thing about the life course is that what I like about it is that it integrates the biological. So it doesn't, as you may have felt in some of the readings that you've done, there's this disconnect. There are researchers who focus so much on the structural influences and say nothing else matters. And then there are researchers like, for example, the article that you read by Glantz and Bishop at the beginning of the semester, that focus very much on the behavioral aspects. There are researchers who focus on the biology and the genetics of individuals. What is really important in the life course is the fact that it integrates biological, psychosocial / behavioral, and structural influences. So it takes all of these factors into account. Now, this is really exciting and important about the theory, but what this means is that it makes things a lot more complex. Okay, then it becomes extremely complex to study health outcomes like diabetes in late adulthood, the onset of dementia, for example, reasons why some people have early onset of hypertension. The analysis really needs to take into account biological exposures, psychosocial exposures, and structural determinants as well. Yes, Melody, I will talk, yes, I will mention neural tube defects in a minute. Okay. So the life course theory is fundamentally concerned with fundamental causes, but in addition to that, it's concerned with the dynamic interaction between these fundamental causes, the structural factors, and the individual biography. And the individual biography is about the biology of the person, is about the individual experiences, the family experiences, the psychosocial, behavioral. That's what I would call the individual biography. So it's the dynamic interaction between the individual biography and the structural / fundamental conditions over time. And over time is a really critical point in this definition, that it's not just about what is happening now. If I want to think about my risk to hypertension at my age, it's not only about what I'm doing now, what the food that I eat now, whether I exercise, whether I smoke. It's really about my all the exposures that I've had throughout my life. Does it take into consideration genetic factors? Yes, absolutely. So the biological is very much related to the genetic as well. Yes, indirectly, or I mean, there's actually a really important line of research right now that looks at the intersection of the genetic and the environmental exposures. So if you have two groups of people, let's say one group has a genetic predisposition to a health outcome, and another group does not have this genetic predisposition. How do, under certain structural conditions, how do members of these two groups over time, how does the risk to, let's say, dementia, the risk to other cardiovascular disease or diabetes or hypertension, how does that risk develop over time, considering both the genetic predisposition as well as the structural, the fundamental conditions that they've experienced over their life course. Okay. Oops. Okay. So this is a bit cumbersome. I keep moving the chat. So there are people who have spent their lives basically doing research on the life course. A lot of this research is actually done in Europe because the data allows, basically there are data that allow people to do research on the life course. And I'll describe some of the data that's available, and I'll tell you what we're trying to do here with some research on aging that we're conducting in the Faculty of Health Sciences. So these individuals, Gallo Bardis, John Lynch, who was my teacher actually, and George Davies Smith, have done a lot of research using data looking at basically childhood socioeconomic circumstances and mortality and health outcomes in adulthood. So they've done a lot of research, and then years later, they've done systematic reviews, and these systematic reviews, pretty much 90% of what was included in this systematic review, for example, is actually their own research, their own studies. One of the first studies on the life course was carried out by George Davies Smith in Scotland, where they followed men. They followed men for many years, and they they basically collected data retrospectively. Okay, and there are limitations of collecting data retrospectively, as you all know from your epidemiology courses. However, they would, let's say, interview, unfortunately, the study by George Davis Smith, the first study, included only men. Okay, so they would interview men at the age of 40. And they would ask the men at the age of 40, when you were 12 years old, what was your father's occupation? What was your mother's level of education? How many rooms did you have in the house? Okay, or some of the questions are, was there a time during when you were 12 years old, was there, or when you were between, let's say, age 10 and 12, was there a time where you didn't have enough food to eat in the house? Okay, so these measures are considered to be childhood socioeconomic measures. Now, they are, of course, limited by the fact that they are asked retrospectively, but in fact, they have been proven in so many studies to be really good and valid measures of really concrete measures of childhood socioeconomic circumstances, despite the retrospective nature of collecting this data. However, this data is collected in mid-adulthood. This is not collected in old age. So if I'm 40 years old and you ask me about my life with my parents when I was 12 years old, I will recall that, most likely. However, if I'm 75 and you ask me, there will be issues related to validity. Okay, so this first study by George Davis Smith found that individuals who lived in disadvantage when they were children, in fact, when they were followed up over time, they were more at risk of developing cardiovascular disease. Okay. Now, this systematic review is on mortality and not only cardiovascular disease. So it's a systematic review of all of the studies that have looked at childhood socioeconomic circumstances and mortality in adulthood. Mortality, of course, is one of the most valid health outcome that you can measure. So, so this is the article if anyone is interested in reading it, if this is something that you're working on. And I'm just going to present two findings from this systematic review. And this systematic review from 2004 was updated later on and included more studies that included women, in fact, because that's a problem. As you read in the Corna article, one of the critiques of the life course is that really it doesn't take gender seriously into account. Okay, so one of the main findings from the systematic review is that cardiovascular disease mortality is determined by what's called an accumulation of disadvantage, of socioeconomic disadvantage across the life course. So it's not only about in adulthood, whether the person smokes or not, whether the person is wealthy or not. It's also about what was happening in their life in young adulthood. And young adulthood is like age 18 or 20. And it's also about childhood socioeconomic conditions. Okay, so that's cardiovascular disease mortality. At least the evidence they looked at in their systematic review highlighted that cardiovascular disease mortality is really about the accumulation, or is really affected or determined by the accumulation of socioeconomic disadvantage across the life course. Let's look at another health outcome: stomach cancer. The systematic review basically shows, and of course studies on stomach cancer are much fewer in number compared to cardiovascular disease. But stomach cancer is a health outcome that is determined by socioeconomic status in adulthood but it's also determined independently by socioeconomic status in childhood. Meaning, poverty, living in poverty in childhood independently contributes to a person's risk of stomach cancer, irrespective of whether this person became wealthy, in adulthood. If they were poor in childhood, they had a higher risk of stomach cancer compared to people who were not poor in childhood. Okay. Now, this is a limited number of studies, of course, because these studies are, in fact, extremely expensive. And they are studies that you can do if you live in Finland, or, I mean, if you are a researcher in Finland, or in some of the countries that invest like 2% of the GDP in research, something like that. So really, it's the type of studies that you can carry out in countries that have really strong research infrastructure, that invest in research and collect this type of data. Because as you've read in the Whitehall, in the article on diabetes, using the Whitehall study, which is data that was collected in the United Kingdom, the Whitehall has been following up people for like 3-4 decades. And you can imagine how expensive it is to set up a study to follow thousands of people over the course of decades. So the study that you read, I believe I mean, they had like 18 years of follow-up. Okay. Okay. Any comments or feedback on this?
Doctor, so they excluded the pathogenic cause of gastric or stomach cancers, and when they did their study?
I haven't read the individual studies. I only read the systematic review. But yes, you're right. I mean, with stomach cancer, there's, I mean, one of the factors is the pathogen, right?
H. pylori. Yeah.
H. pylori. I actually, we need to go back to the original article, but I would also suspect that H. pylori would be like smoking. Like the fundamental cause would be poverty. H. pylori would be the mechanism, and stomach cancer would be the outcome.
I think H. pylori is treatable, but it's not often diagnosed. And they don't diagnose it conveniently. It takes a long time before they realize they have the ulcer and they culture positive.
Right. Right. I mean, also stomach cancer is very much, well, I mean, at least some of the readings I've done is very much related to eating preserved food, canned food and preserved food. And people who live in poverty, at least in some countries around the world, are a lot more likely to eat canned food because it's cheaper than fresh food.
Exactly.
Okay, so canning, you know, the preservation of preserved meat by salt and canning is a risk factor for stomach cancer as well. Yeah. Yeah, so H. pylori is treatable, but the issue is also, as Mahmoud was saying, is how long it takes to diagnose it. And that's, again, it's determined by fundamental causes like access to knowledge, resources, health insurance. Okay. Antoine. Yes, but very hard and takes long to treat. Yeah. Yeah. Okay. So it's like I have given up on it. What do you mean you have given up on it? On H. pylori? Frank? Ah, you have it? Is it treatable with antibiotics or with
Hello?
Yes.
Yeah, hi, doctor.
Hi. What do you know, Antoine? Is it treatable by antibiotics?
Yeah, it is with antibiotics, but it needs like a multiple regimen with several antibiotics at the same time.
Mm.
And it takes like 2 to 3 years or something like that of daily intake.
Wow.
So yeah.
Okay.
And its diagnosis as if the doctor is capable is actually easy. You just need the breath test. So
Okay.
you blow into a tube, and it's in like 30 seconds. It tells you whether you have it or not.
Okay. Okay.
Yeah.
So Frank, I didn't mean to scare you, of course, but I guess this is something to follow up on. Okay. Okay. So let's look at a couple of the concepts related to the life course. One of the concepts is what's called the critical period. It's actually not mentioned in the Corna article, but the other pieces, there's also someone called Kuh, K-U-H, who has written a lot on the life course and chronic diseases in old adulthood, and has written about the critical period and the sensitive period. But the critical period really is if an adverse exposure takes place in a critical period, it can result in permanent and irreversible damage. Okay, so the critical period is different depending on what we are talking about. So when we're talking about neural tube defects, we're talking about the first 28 days after conception. Okay, the first month a woman gets pregnant, in many cases, before she knows that she is pregnant, that is the critical period for the neural tube to close. And if it doesn't close because of any reason, then that can result in permanent and irreversible. I mean, I don't know how irreversible it is, because even like a neural tube defect can be closed, okay, with surgery, of course. Okay, so that's a critical period. There's also, like, for example, exposure to secondhand smoke in utero is a critical period, or at least a sensitive period, meaning that exposure to secondhand smoke in utero is worse than exposure to secondhand smoke at age 3 or age 4. I mean, we'll talk about lead exposure now. During a critical period in early childhood, exposure to lead can have irreversible damage on the development of children. What the Corna article reviews and addresses are 3 points. The first one, what's called cumulative advantage and disadvantage, meaning how much does the person accumulate over their life course in terms of exposures to adverse socioeconomic conditions. I mean, is there a difference between someone who's exposed to adverse socioeconomic conditions in childhood, but then they do well, their conditions improve as they get older? What is the difference between that situation and a situation where a person lives in poverty in childhood, then poverty in early adulthood, then poverty in late adulthood? There's an accumulation of disadvantage. On the other side, there's also an accumulation of advantage. You know, in early childhood, an individual can have advantage, can, go to a private school, can do well, can go to a private university, get a good paying job. So an accumulation of advantage over their life course. We shouldn't always talk about disadvantage, because on the other side, there's the accumulation of advantage as well. Then the other concept that the Corna article talks about is what's called the trajectory or a pathway, and which is something I'm interested in looking at in the case of early marriage. What is the trajectory from early childhood until age 15, 14, 15? What is the trajectory of girls who end up marrying at age 15? What happened to them when they were 5, when they were 6, 10, 11? When did they drop out of school? So the trajectory is what happens to the person over time, and how does it change? How does their trajectory change? Does it improve or does it get worse? It's different than the accumulation. So the accumulation is how much more. So disadvantage over disadvantage over disadvantage accumulates, then there's three times an accumulation of disadvantage. Whereas a trajectory is more about, does the person's life or exposure get better or worse over time? The diabetes example, actually, the article on diabetes looks at that. And we'll talk about it in a minute. Then there's this concept of age as leveler, which is basically the opposite of the cumulative disadvantage. And what this concept says is that even if someone is exposed to adverse conditions in childhood, as they get older, they can reduce the impact of that early childhood exposure. So age is a leveler. So over time, the concept here is that over time, individuals who have been exposed to adverse conditions and individuals who have not, they sort of converge, because age sort of takes care of, improves the situation for those who have been exposed. It's actually the opposite of the main tenet of the life course theory. The life course theory says that if a person is exposed in childhood, then they are impacted for the rest of their lives. The age as leveler is basically suggests that no, as people age, as they get older, then they can reduce the impact of this adverse childhood exposure. Okay, these are just concepts, and basically they need to be tested in research. These are sort of like hypotheses related to the life course. Okay, so let me stop sharing the slides here, or wait, can I? Okay, I want to share with you actually a video now. Before that is, oops, no, wait, 1 second. Okay, does anybody have any questions so far or comments? I'm going to share this video with you. It's 4 minutes. I thought it was 2 minutes.
Of government at all levels, local, state, and federal officials. We all failed the families of Flint. Not a day or night goes by that this tragedy doesn't weigh on my mind.
My home used to be a place of comfort and safety for my family. It used to be what a home should be, a place of peace and protection from the outside world. That was taken from us, and not just from my family, but from every home and every citizen in Flint. Now my home is known as Ground Zero. In 2014, a decision was made to switch the water source without the proper testing and enforcement of regulation.
The only thing I can conclude is that they don't care about children lead poisoned from drinking water. Why do you think the EPA has this problem? I mean, that's a pretty strong statement. You would have to ask them why they refuse to do the job they're paid to do.
one ward, Ward 5, where the water lead levels were the highest, the percentage of children with elevated lead levels actually went from about 4% to almost 16% of kids.
The only job that's more important to me is the job of father. And I know that if I was a parent up there, I would be beside myself that my kid's health could be at risk. To you, the people of Flint, I say tonight, as I have before, I'm sorry and I will fix it. Now let me ask you something else. Are the people paying right now in Flint for water they cannot wash in and cannot use and cannot drink? This is not a third world country. Are they paying those bills?
Everyone deserves safe drinking water, and that's the expectation. Do you solemnly swear or affirm that the testimony you're about to give will be the truth, the whole truth, and nothing but the truth?
We had what we needed in place to prevent this from happening.
Really? But then why did it happen?
Because the state didn't implement and enforce appropriately.
I took immediate action as soon as I learned there was a lead issue. We started issuing filters to people, doing water testing, doing blood testing.
Does that mean I don't have regrets? Because I'd really like
No,
to
that's a whole different standard. Everybody can say that's cheap.
Governor
To be open with
Snyder,
you, I wish more would have been done.
Plausible deniability only works when it's plausible.
It's something different to have this continuing dialogue to say it was solely us. This could have been stopped sooner if other people could have also spoken up.
People who put dollars over the fundamental safety of the people do not belong in government. And you need to resign too, Governor Snyder.
Let me be blunt. This was a failure.
Okay. Okay. So this is, oops, let me put this here. This is a big thing that happened a few years ago where a town called Flint, this is in the US, a town called Flint, basically the whole population was exposed to lead in the water that they were using. And as you know, I mean, in Lebanon, people buy water, but in many other parts of the world, you drink tap water because it's supposed to be clean. People pay taxes in order to get clean water in the tap. Okay, so we have this situation where there's a population that lives in what's called a post-industrial town, a town that has been basically abandoned by businesses, by factories, by politicians, and people are there fending for themselves, you know, a very high unemployment rate, and neglect, total neglect. And then you have a situation where people then became exposed to lead in the water, okay? In particular, children, small size, because of their small size, have been exposed to lead. What do you think? Let me go back one slide, actually. In this slide, actually, I just tried to put in some recent research, not very recent, this is from 2001, but some research actually that has established an association between exposure to lead in the blood, even less than 4, actually, not just 10, and a host of health outcomes. For example, cognitive development in childhood, delinquency in adolescence and early adulthood, and even hypertension later on. Okay, so if we want to think about, through a life course framework, about what would be the outcome of this exposure. If you think, let's say we're starting off here at age 3. And this exposure to lead, you can think of it as socioeconomic disadvantage. It's children who live in poverty who were more likely to be exposed to lead because of government neglect. I see Fatima's hand. Yes, Fatima.
Hello, doctor.
Hi.
Since lead affects the brain and the nervous system development, it will definitely affect their learning capabilities, and they will have behavioral problems because it's associated with the nervous system. This will decrease their chances in life in getting a proper education and a job and success.
Okay. Okay. Yes, absolutely. Here, if we think about through a life course lens, you have a socioeconomic disadvantage that in fact leads to biological disadvantage. Usually we think, we start from biology, but in fact, this is a case where it's the disadvantage that has introduced, the social disadvantage that has introduced this biological reality, the lead in the blood. Over time, then, as Fatima mentioned, the cognitive development of children who are exposed to lead is slower. When they are in first grade, second grade, third grade, whatever, they're not doing well academically. Since they are children who were exposed to lead because of poverty, there might be another insult here related to the quality of the education they're getting, the schools that they go to, because they live in poverty. So you have an accumulation here. You have another disadvantage that is being introduced. Okay, so this child is growing up. We're going through the life here. So let's say at age 5 or 6 in first grade, the child is not doing well in school. They're, in addition to the exposure to lead, they also go to poorly resourced schools. Yes, I see that Melody wrote dropping out of school. Okay, so a child who's not doing well in school, at some point, at age 14, 15, whatever, they drop out of school. So this is another an introduction of another social disadvantage. Dropping out of school, they may join a gang, for example. This child may start to engage in either like even smoking, but also antisocial behavior, engaging in theft and delinquent behavior, substance use. Yes. Okay, so we're following basically this trajectory of this, both it's a trajectory, but it's also an accumulation of disadvantage over time. Okay, and then one of the things that, with evidence that is accumulating right now is that lead exposure in childhood is also associated with early onset of hypertension. So here you have, again, a population that, let's say at age 30 or 40, would have a very high risk of hypertension, whether, irrespective of other socio-behavioral factors, psychosocial factors or behavioral factors. Because of the exposure to lead, also they have this biological risk for hypertension. I haven't read a lot on dementia, but I would be interested, in fact, Lamia, if you have anything, you can share it with me.
In fact, The article the first article that you posted was talking about the same pathway and the accumulation and the education and the cognitive development and how it can lead to, in fact, early diagnosis for dementia.
Sure. Yeah. Dementia is absolutely an outcome that's been studied extensively through the life course. Yeah. Okay. So then, I mean, just thinking about this example of lead exposure of lead in the blood and the pathway and the trajectory that individuals can go through, then basically this is convincing evidence that a life course approach is really critical to our understanding of socioeconomic inequalities. So school dropout, delinquency, hypertension, inequalities, and these outcomes is pretty much, and pretty much outcomes that we need to study through a life course approach. And in this case, policies and efforts to maximize, to minimize exposures to these early life disadvantage or insults becomes really important. So for all of you who, whether you are in public health, nursing, nutrition, then, it's absolutely, from a life course approach, it's absolutely not sufficient to think about the risks that an individual experiences now at this moment. If you want to think about diabetes or hypertension or any other health outcome, it's really important to go back and try to understand what the life course exposure has been of this individual. I don't want to go over this. This is a bit outdated, but this is an example. I'll go through it very quickly. But this is an example of what we talk about, what we mean when we talk about life course policies. Life course policies basically are not related to policies of educating people about healthy diet when they are 40 years old. They are policies that come in and intervene and make a change to reduce exposure in childhood. So there's a program in the United States called the Head Start program, which was started in 1965 through the framework of what's called War on Poverty. And the Head Start program basically enrolls children who are 3 and 4 years old who come from poor families, enrolls them in preschool programs. Okay, so instead of these children staying at home, not receiving any cognitive, what is it called? Cognitive activities or challenges, they are enrolled in preschool. They go to preschool every day. They learn things in preschool. So before they start first grade, they get some preventive medical care, they get a nutritious meal at school, and then their parents also, their primary caregiver is engaged in like parent-teacher association programs. So the idea is that this Head Start or this preschool for children who live in poverty confers physical, emotional, and cognitive benefits to children who would have not have received this support if they just stayed home. So the idea is that this Head Start program will have short-term impact. And this short-term impact is that the children at age 6 will ease into first grade and will do well cognitively and emotionally in terms of adapting to school. So this is a short-term impact, that there will be an impact in first grade, second grade. But then there's also this idea that there's a long-term impact of the Head Start, nutrition in early childhood, cognitive development in early childhood, then should have long-term impact. And what they've looked at in terms of evaluating this program, I won't bore you with the details. What they've looked at, we'll go to the next slide, is that they looked at whether children who went to Head Start, who were enrolled in Head Start, compared to children who did not go to Head Start and didn't go to other daycare, who stayed home, whether they were more likely to complete high school, whether they were more likely to attend university, have higher earnings, and less likely to engage in delinquent or criminal activities. Again, this is a longitudinal study. It started with people who were born in 1964 and followed up basically, and like in the 1990s, they followed them up and asked them if they've completed high school, went to college, how much they earn, and if they've ever been arrested for criminal activity. What they found, actually, is that controlling for SES, of course, they found that children, I mean, it's counterintuitive to control for SES because children who live in poverty, basically qualify for Head Start. They found that children who attended, or individuals who attended Head Start in childhood were more likely to graduate from high school, more likely to attend the university, and more likely to report higher earnings, and less likely to engage in criminal activity. Okay. If you even think about something like smoking, and you think about Lebanon and the data that you looked at for your third assignment, and when you think that people who have secondary education or more are less likely to smoke, and then you have an intervention in childhood that increases a person's likelihood of graduating from high school, then you can think of that as actually a smoking intervention. Okay, you don't need to go back to people at age 20 and tell them that smoking is bad for you. By the fact that they've graduated from high school, they are a lot less likely to smoke. However, because this is a program in the United States, and as you all know, and I don't know if some of you are following up with the news and the George Floyd court proceedings, the police, racism in the United States impacts the effectiveness of some of the best and most well conceptualized interventions. So what they found out is that the Head Start program actually had a much better effect on white children than on Black children. And the argument is that even if you provide this protection to Black children in early development, then as they go through their life course, they will be encountered with many insults related to racism that go against this protection, that diminish the impact of this protection that they were provided with in early development. Okay. Are there any comments?
Yeah, all good.
I'm not sure if this is all new information and you're absorbing it, or if it's difficult. Okay, I hope that it's clear.
It makes perfect sense. I mean, we have to look at the far vision of the problem, not at the short vision.
Yes. So this reminds me of the first time we met, and some of you, of course, very well intentioned, mentioned that you want to raise awareness, basically educate people and raise awareness. Of course, this is very well intentioned. We all want to improve people's health knowledge, improve their communication, and raise their awareness that smoking is bad. You need to exercise. You need to eat healthy food. But I hope that by the end of this semester, we move away from that and we start to think in a lot more complex way about all the factors that influence basically inequalities in health outcomes that are beyond, awareness. I'm going to keep the critiques of the life course. Maybe when we do the session on feminism intersectionality, we'll come back to this because I want to talk about the diabetes article. I want us to talk about the diabetes article and come back to this slide actually on the research that we are doing on aging in Lebanon. And the study is called SAWA, and it's an acronym. It's a study of aging, well-being, and we are still not sure what this last A will be. If you can think of anything, it should not be Alzheimer for sure. We don't want the word Alzheimer to be in the title. But if you can think of any nice word, send me an email. So it's a study of aging, well-being, and A in Lebanon, Sawa, Lebanon. This is a big study. We're very excited to have it. It's a collaboration with the University of Michigan. And the researchers from University of Michigan are Carlos Mendes de Leon and Zainam Naimne, who's Lebanese, as you can tell from her name. And the PI is Dr. Monique Shaya, and the co-PIs are myself, Martine Bijani from medical school, Dr. Hala Ghattas, and Dr. Abla Sibai, our dean. Okay, so one of the things that I'm working on right now is developing socio-demographics measures to use in this SAWA study. We need to develop the best measures of socioeconomic status in Lebanon that are contextually relevant, that are like with the few as possible measures that capture socioeconomic status in the best way. And of course, we want to develop measures of socioeconomic status in childhood. This is probably going to be the first study that looks very carefully into socioeconomic status in childhood in the context of Lebanon. We want to look at measurement of wealth in old age, not only income and education, but wealth. What do people have now? Okay, in terms of property, pensions, remittances, and particularly, we want to think about measuring the impact of shocks that people have undergone throughout their life. Of course, civil war is one shock. If we're talking with someone who's 60 or 70 years old, they have lived through the civil war as adults. And then now, unfortunately, of course, the economic collapse is a huge shock that people who are in retirement or who are close to retirement and who have been thinking that, oh, great, I have my pension, I have everything that I saved, and now they're finding that their savings are worth less than 10% than what they thought 2 years ago. Okay, so that's what we are doing here. And we're looking at a number of studies that look at health outcomes in old age, or at least in adulthood, that have used the life course lens and that have measured socioeconomic position across the life course. So we're looking at studies on dementia, we're looking at studies on mental health, on diabetes. It doesn't matter because we're going to measure all of these outcomes in the SAWA study. However, the trick is that we want to have really good measures of socioeconomic position across the life course. So this diabetes article actually falls into some of the articles that we are consulting with in order to improve our ability to do our research in Lebanon better. So this study, and I hope those of you who are in the public health nutrition have found it interesting. But this study has looked, I mean, it starts out by saying, of course, we all know that the risk factors of type 2 diabetes are obesity, physical inactivity, and poor diet. Okay, everybody knows that. However, what are the fundamental causes of type 2 diabetes across the lifespan? What is it that puts people at higher risk of diabetes since they were born until they are 40, 50, 60 years of age, that are both, you know, maybe socioeconomic, but also maybe biological? Let me see if I can move this here so you can see the bottom of this slide. Okay. So what they've looked at in this study, and it's okay, don't worry about, you know, hazard ratio and the methodology. And let me just tell you that this is a study in the UK, the Whitehall study in the UK. Michael Marmot is the PI of this study. And it's a study that has followed up people for decades, basically, looking at basically what happens to people's health over time, depending on the risks that they've been exposed to. So what they tested in this article are 3 things. The first is that, okay, wait, before we talk about the 3 things that they tested. Their measures of life course are very crude, actually. So they asked the person about their father's occupation, and I believe at age 12, or maybe age 16, but most likely age 12, depending. I need to check again. But the father's occupation in childhood is considered to be the person's socioeconomic status in childhood. Because if your father is, if a person's father is a medical doctor, let's say, then that person would have high socioeconomic status. If the person's father has unskilled, worked in a factory in the context of the UK, then they would be considered, the father would have an unskilled job and would be considered as a low socioeconomic status in childhood. Then education, the person's my education, not my father's education, but my education is really my socioeconomic status in early adulthood, because education, you accumulation by age, in most cases by age 25. People who do medical school and whatever, graduate school, maybe a little bit later in life. But by age 30, basically the person's education, it tells me that my internet is unstable. No, anyways. Okay, so education is socioeconomic status in early adulthood. And then the adult occupation, like at age 40, what was your occupation? Were you, what was your occupation? And that's the third measure of socioeconomic status. So they had 3 hypotheses they wanted to test. The first one is whether there's a latent effect of childhood socioeconomic position on diabetes, meaning if the person had low socioeconomic status in childhood, irrespective of anything else, are they more at risk of diabetes? The second hypothesis they wanted to test is whether the accumulation of disadvantage, so disadvantage and more disadvantage and more disadvantage, basically increases the risk of diabetes. And then the third hypothesis they tested is about trajectory, meaning it's not about accumulation, but it's more about whether your socioeconomic status improves or gets worse as you get older. Meaning, did you have high socioeconomic status in childhood and then you had low in adulthood? Or did you have low socioeconomic status in childhood and then things improved for you? And is that improvement, from low to high, does that improvement protect you from diabetes? Okay, so these are the 3 hypotheses that they tested. And I'll show you the results, first, this is very similar. This is in the article, but very similar to actually the model that we have been looking at since the beginning of the semester, where you have the structural, which is the life course socioeconomic adversity on the left side. And then you have inflammation as a pathway. And whether basically the impact of the socioeconomic adversity goes through biological and inflammation factors to increase a person's risk of type 2 diabetes, or is there a direct pathway between socioeconomic adversity and type 2 diabetes? So let's talk about inflammation. Inflammation, we tend to think of it more in like infectious disease. If I get an infection, then I get these white blood cells and my body is inflamed and I get a fever. Okay, but also inflammation is addressed in chronic conditions, whether it's acute or chronic inflammation. For example, arthritis is an inflammatory disease, meaning the body starts to fight itself and is inflamed. And I don't know much, I haven't read much about diabetes as an inflammatory disease, but this is the idea that basically adversity, whether it's in childhood, or whether it's accumulated, whether it's a trajectory, adversity, socioeconomic adversity increases the risk of this inflammation that increases the risk of type 2 diabetes. So here you have a social factor that leads to a biological change in the body, the inflammation. The chronic stress or chronic exposure to adversity leads to inflammation, and then the chronic inflammation increases the risk of type 2 diabetes. Okay, so these are two figures that I got from the article, and they're simple, really. Don't worry about whether it's a hazard ratio, or just look at the bars. It's not the hazard ratio actually here. The bars here basically tell you that if we, okay, well, before we say that, their results showed that the latent hypothesis is not true. So they found that adversity in childhood, only adversity in childhood, does not increase the risk of diabetes later in adulthood. Okay, the body overcomes this adversity in childhood if they are given a chance. But what they found out is that cumulative disadvantage, this first set of bars, cumulative disadvantage, and trajectory from low, a trajectory where the person has low socioeconomic status in childhood and low socioeconomic status in adulthood, that these two types, the accumulation of disadvantage and keeping, low, or going from high to low, increases a person's risk of type 2 diabetes. Okay. So again, what this graph shows is that as socioeconomic status accumulates, so that it's low, the person's socioeconomic status across the lifespan is low, then there's a higher risk of type 2 diabetes. People who have a trajectory from high to low or low to low socioeconomic position also have a higher risk of type 2 diabetes. Okay, so these crude results just say that, yes, absolutely, type 2 diabetes is impacted by socioeconomic disadvantage across the life course. But these are crude. Now, this is called C-reactive protein. I really don't know zero. I know zero about inflammatory markers and C-reactive protein. Those of you who come from a biology background or maybe in nutrition know about this. But this is what was one of the things that were studied in the article, is they got blood samples and they looked at C-reactive protein, which is an inflammatory marker in the blood. Similarly here, similar to type 2 diabetes, they found that the accumulation of socioeconomic disadvantage and a poor socioeconomic trajectory increase the risk of having this inflammatory marker. Okay. Yes, Melody.
Yes, hi, doctor. I wanted to ask you, is this, it takes into consideration obesity? Does
Okay.
it like, because also obesity is actually associated with like an increased fat, and the increase in fat increases the inflammatory markers, which also increases the risk of type 2 diabetes. So how can we see that, is it like controlled for obesity and other factors?
Not yet, not in these graphs, not yet. This is a good question, but not yet. These are crude. However, in this in this figure? Yes, it is. Okay, so this is what, let's look at the hazard ratio for type 2 diabetes when we think about the cumulative socioeconomic disadvantage. These are hazard ratios, and forget about what hazard ratio means. Hazard ratio is basically not like an odds ratio. The odds ratio tells you whether an event happens or not. The hazard ratio tells you when this event happens. It's used in survival analysis, meaning, okay, it's not only enough to know whether I get diabetes or not. Researchers also want to know, when do I have the onset of diabetes? Do I have it at age 40 or do I have it at age 60? Because it makes a big difference. Okay. Anyways, so here, what this, let's look at the top. Let me see, where is the annotate? Spotlight. Okay, let's look at the top. And I'm happy actually with this article because I would like you to think quantitatively as well. We read quite a few articles that were qualitative and very interesting, but very interesting to me. I don't know what you thought, but I also think you really need to be able to read and think about quantitative data as well. It's very important. So here, this is a model that is looking at the risk of, through the hazard ratio, at the risk of type 2 diabetes, only including socioeconomic status. Okay. But then, so this is one model. If you're used to seeing logistic regression models, you see we always, first we have like the crude model, and then we start to add risk or covariates to it and see what happens. So what happens here is, when they added smoking, when they added physical activity, when they added diet and BMI, the risk of diabetes went down because they took all of these things into account. When they added all of these behavioral risk factors, yes, the risk of type 2 diabetes went down, but what do you see? The hazard ratio is around 1.6. Okay. So people who have an accumulation of socioeconomic disadvantage, even if you control for all of these risk factors, they are 1.6 times more likely to develop type 2 diabetes than people who don't have the SES disadvantage. So of course, if you include more covariates and you include all of the diabetes risk factors, yes, the risk will go down, but it didn't go down to 1. It was what's called attenuated in the language of statistics. We say that the risk attenuated, but it didn't disappear. It's remained significant. Okay. Yeah. Then they added the C-reactive protein and then another inflammatory factor, and they added both. And they found out that actually, if you add the C-reactive protein or both C-reactive protein and ILS6, yes, you reduce, you reduce the risk of diabetes. You reduce it by 30% or so. I remember that they said 30%, but it does not eliminate the effect of socioeconomic status over the life course. Okay. Okay. So, oops, I didn't mean to do that. What did I do? It went out. Oops. Just to reiterate here, what this is showing, that the accumulation of socioeconomic disadvantage increases the risk of type 2 diabetes. When you control for behavioral risk factors or the risk factors for diabetes, yes, the risk goes down, but it doesn't disappear. When you control for inflammatory factors, the risk goes down, but it doesn't disappear. And when you go control for all of the risk, you know, the behavioral and the inflammatory, then it goes down further, but it doesn't disappear. So what this is saying is that, yes, risk factors and inflammatory factors, markers, are explaining some of the risk, but they're not explaining all of it, which means that the accumulation of socioeconomic disadvantage is still an important determinant of type 2 diabetes in adulthood. Okay. So that's all I wanted to say. Yes, Reem, go ahead.
Sorry, doctor, can you repeat the conclusion? My internet was cutting.
Yeah. Okay, there I just saw these comments also. So let me repeat the conclusion. The conclusion is that through this study, which basically followed people up and looked at socioeconomic position throughout their life course, what the results showed is that the accumulation of socioeconomic disadvantage increased the risk of type 2 diabetes. Okay, then somebody would come and say, but it's not only socioeconomic disadvantage, it's also because these people smoke and are obese and whatever, all these other factors. So by controlling for all of the diabetes risk factors, yes, absolutely, the risk reduced or attenuated. However, it didn't disappear. The risk was still 1.6 hazard ratio, and the confidence intervals did not cross 1. The confidence intervals remained significant. Okay, then when you control for both the behavioral risk factors for diabetes and you control also for these inflammatory markers, the risk also attenuates and get closer, but it doesn't gets smaller, but it does not disappear. Which means then the interpretation is that the accumulation of socioeconomic disadvantage still increases the risk of type 2 diabetes even after controlling for behavioral risk factors and after controlling for inflammatory markers. That some of this risk is explained by inflammatory markers, but not all of it. Okay. So let me read these comments. So Lamia says, there's a Harvard study that addresses the early adversity and it linked to mental health and addiction in adulthood. Also, Dr. Matei work focused a lot on childhood development and trauma and its impact on adulthood. Okay, yes, absolutely. Thanks. So SES is significantly associated with type 2 diabetes independently of stress markers, diet, smoking. Not necessarily independently. But it's above and beyond. Yes, you can, I mean, I wouldn't use the term independently, but I would say it's above and beyond behavioral risk factors and above and beyond inflammatory markers, an accumulation of socioeconomic disadvantage across the life course, lifespan, is a risk factor for type 2 diabetes. Okay? Okay. Unless there are any other comments or questions, I'm going to close these slides because I have something nice to tell you about. We have 2 minutes, but I'm going to take 5 more minutes of your time. It's not something nice, but I'm just being sarcastic. It's something important, not necessarily nice. Let me see if I can move this. Oh. Okay. Okay. So it's this. And we will talk about this for the rest of the semester. Don't worry, every time. But I want to introduce you very quickly. This is posted on Moodle already. I wanted to introduce you to the final paper. By the way, all of you are doing well in the course, and you know that you will receive something from Ms. Lama Al-Qadi. You know, you will not, none of you will receive anything about hpch331. Okay, but this is the final paper, and I'm giving it to you now, even though the due date is like in mid-May, because I want you to work on this paper. It's 40% of your grade, which is really significant. I want you to start working on it now, whenever you have time, around your other assignments. So just very quickly, for this final paper, you're requested to select one of the structural theories discussed in the second half of the course. And I would include social relations, social networks, fundamental cause theory, life course theory, syndemics, which we're going to discuss, which is a framework more, and then the feminist theory, intersectionality. I would like you to select one of those, and then a health outcome that you are interested in. Whether you're working on it for your thesis, for your practicum, for your whatever, you know, anything, you know, something you want to work practically on after you graduate, but something you're interested in, because you're going to spend a month or more working on this paper. So it's much better if it's something that you like. Okay, and you need to let me know. So, and then what I would like you to do is write a critical literature review in which you examine the health outcomes through one of these theoretical lenses. One. You don't need to do more, because if you do more, then you won't do it justice, and then your paper will not be strong. Just focus on one. Okay, so the paper is only 4 to 6 pages. It's not a lot, really, but sometimes it's more difficult to write shorter papers. Double spaced, 12 font, well, 1 inch, okay. So let's say if it's 4 to 6 pages, let's say your paper is 5 pages, you need to have at least 10 references, 10 good references, theoretical references. And then you need to mix well between theoretical and articles on the specific health outcome that you're interested in. Please use your references wisely. So don't like use a reference. There, you know, WHO says that there are 4.5 million people who have, I don't know, diabetes. Okay, that's a reference, but it's not using it wisely, because, yeah, a reference should really be either a theoretical article or an empirical study that you really get a lot out of to help you move forward your arguments and your ideas in the paper. Use the APA style and write well and pay attention to clarity and grammar, because for the final paper, I'll actually assign a bit more on the quality of the writing. Okay, so what are my recommendations? My recommendations, and these are not just recommendations, these are also deadlines, but they're really simple deadlines, and they are to help you. If you don't abide by these deadlines, you're not going to get any points off. But then, you know, I would not know whether you're on the right track or not. And it's much, much better that you abide by, you know, send me things by these deadlines so that I know. If there's a big issue that we need to work on, I'll let you know. So begin the process early, decide on the theory and the outcome by April 8th. Okay, at least the outcome, you need to have it by April 8th, because you know what you are interested in, and you know what would be easier for you to work on. The theory, if it's not ready by April 8th, which is next Thursday, you can maybe put 2 theories and start playing around with Scholar Google and seeing, you know, which one fits better, which one has, you know, would help you better in terms of your literature search. Okay, and then start the literature review as soon as possible and develop a preliminary reference list by April 15 and send me that reference list. And please do not send me just whatever you get, you know, a reference list and then change it. No, spend some time doing a literature review and decide on really 10 references that, at least 10 references that you think you will really use in your paper. Okay, so invest in this step because it will help you. Okay, and then what I recommend is that you really spend time every week, not a whole day, but maybe 3 hours, 4 hours, 5 hours every week on this paper, rather than waiting until May and spending 2 days on the paper. Your paper will be much better quality if you spend 3 to 4 hours or 5 hours every week in April working on it. Okay, because your ideas will develop slowly rather than, you know, you'll be under pressure. Okay, consult with me as you move along in the process. I will schedule individual meetings during the week of April 19. So April 19, I will schedule meetings with those of you who send me your reference list. Of course, the reference list will have the theory and the topic and the reference list. And then by April 22nd, submit an extended extended outline. And I can send you some information about what an extended outline is. So an extended outline is not introduction, paragraph 1, paragraph 2. That's a ridiculous outline. An extended outline is you tell me in each paragraph what the idea you're going to address in that paragraph and the references you're going to use. Okay, so that will be basically, that will move you much closer to working on your paper. Then the final thing is that feel free to exchange, okay, it's 5:16. Feel free to exchange drafts of your paper with one of your classmates that you work with and you trust and have a good relationship with. But keep in mind that this is your paper. You're the one who's working on it. You're only going to receive feedback from your class colleague, not your colleague is not gonna help you work on it. Okay, the paper now the paper is due between May 6 and May 12, before Ramadan. Sorry, not before Ramadan, before the Eid. Okay, and has to be submitted on Moodle by midnight, May 12. I need to look into your other assignments. This due date may change a little bit because I know we received you know, when all your assignments are due. So I don't want this assignment to overlap with anything else that you have because I want you to submit really good papers. Okay. However, really, if you start working in April on this paper, you can very well submit it in May, in early May. You can. Okay, but it's up to you. Okay. So I'm just giving you this information. Next Thursday, when we start class, I'll have maybe 5 to 10 minutes to discuss if you have questions. So just sleep on this, you know, think about it. If you have pressing questions, send me an email, and then we will talk about it next Thursday. But next Thursday, you need to send me in an email your topic, and better, it would be much, much better if you also send me the theory. Okay? Okay. So, good. So I'll see you next Thursday. You don't have anything between now and next Thursday except, you know, thinking about this and reading the syndemics articles. Okay?
Thank you, Doctor.
Okay, great. See you all. Bye. Bye. See you.